بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. معكم دكتور ياسر طاقة. Today I'm going to talk to you about one of the important subjects in your surgery with regard to the spine. We talked previously about previously about the degenerative disease of the spine. Now we are going to talk today about the principles of managing patients who are having spinal injuries. I mean fracture and dislocations of the spines, including mainly the sites which are more vulnerable to trauma than others, which are the area of more mobility or junction of the mobile spine with the stable spine. You know that the stable spine are the thoracic spines because they are fixed by the ribs in addition to the posterior ligaments. The ribs will make the thoracic region more stable than others, so that to get fracture of the thoracic spine purely is sometimes difficult. But getting fractures between junctions of the mobile spine, I mean by the mobile spines, the cervical and the lumbar spines. The junction between the cervical and thoracic spines and junction between thoracic and lumbar spine are the most vulnerable areas for spinal traumas, including fractures and dislocations. Fractures and dislocations of this vertebrae are important as they may produce spinal cord and nerve root injuries. You know that the contents of the vertebral column are the spinal cord number one, and from each side of the spinal cord the nerve roots will be exiting. So that any fracture or dislocation of the spine may affect the spinal cord itself or the spine nerve roots. Also, I want you to know important thing about with regard to the anatomy of the vertebral column with regard to the with its relation to the spinal cord. To know that in normal adult, the normal spinal cord itself, I mean the cord itself, cord tissue, spinal cord tissue will end at the lower level of L1, sometimes said lower level of L1 or upper level of L2. Let me say at the end of L1, spinal cord will end. What we left with in L2, L3, L4, L5, and the sacrum are only the nerve roots contained within the dural sac and called the equina. So as you can suspect from this anatomy that the more proximal the injury, I mean, for example, cervical injury will be more dangerous because upper cervical injuries may result in dense quadriplegia with paralysis of all limbs, while lower cervical injuries will result in paralysis of both lower limbs, total paralysis, but may preserve some movements of the upper limbs. I mean, with severe injury to the spinal cord. Then, if we go down after T1, because you know that the brachial plexus have a nerve root from T1 as well. Then after T1, I mean T2, 3, 4, 5 until L1. At these levels, if there is severe and complete injury to the cord, then there will be sparing of the both upper limbs. They are being moving normally, but there will be paraplegia of both lower limbs. Then, if the injury will be at lower level, for example, at the cord equina, like for example L2, L3, L4, then there will be paraparesis, not total paralysis. Fractures are more frequent at the junction of the mobile and rigid parts in the lower cervical and dorsolateral region, as I told you. Regarding etiology of spinal injuries, either traumatic spinal cord injuries or pathological fractures. Regarding trauma, the most important is hyperflexion trauma. This is the most frequent type of trauma, example for a heavy object on the back of the trunk or the head. This will result in flexion of the head or flexion of the trunk. And then there will be hyperflexion trauma. You can imagine that this will result in compression of the anterior part of the vertebra, not the posterior. Hyperflexion and rotation, here there will be both of them, hyperflexion and rotation as well. Vertical compression trauma, fall from height on the feet or the buttock. Here, what will happen? There will be a vertical compression of fracture trauma to the vertebra and fracture of the vertebra. Here you can suspect also that fracture of the calcaneum is common association. Or vertical compression may happen from fall on the head. Example, diving in shallow water will result in vertical trauma to the head, and this will be go down to affect the spines as well. The last type is hyperextension injuries, which are uncommon because you know that when we want to protect ourselves, we would do flexion of our body towards the anterior, not to the posterior. So that hyperextension injuries, yes, sometimes happen, but they are uncommon. The other types or other cause for spinal injuries are pathological fractures, including metastatic tumors or osteoporosis. Now you can see in this image different types of mechanism of fractures in traumatic fractures. Hyperflexion in this one, this mechanism of hyper. Here there will be hyperflexion with rotation, as you can see. This one hyperextension, which I told you it is uncommon. And number four is the vertical compression of the vertebrae. The types of spinal injuries, we are classifying them according to the stability or according to morphology, as you are going to see now. According to stability, we classify fractures of the spines either to be stable fractures or unstable fractures. What do you mean by stable or unstable fractures? This will affect not only the pathology, not only the presentation of the patient, but also how we are going to manage these fractures. Clinically, spinal instability has been defined as the loss of the ability of the spine. I repeat, spinal instability has been defined as loss of ability of the spine under physiologic leads allows to maintain relationships between vertebrae in such a way that there is neither damage nor subsequent irritation to the spinal cord or nerve roots, and in addition, there is no development of incapacitating deformity or pain due to structural changes. So that if these are lost and there is damage, irritation, deformity, or pain, all will result in sometimes instability. This definition of unstable fractures or spine stability with regard to the clinical definition. While radiological definition, numerous sets of radiographic criteria has been developed in an attempt to predict which patients are or will become unstable after spinal injury. In fact, we have many sets of classifications, but I choose to use this one, which is simple and easily understandable by you. The most commonly used is the three-column model of Dennis. In this model, the spine is divided into a posterior column, middle column, and anterior column. Okay, now the posterior column includes all of the posterior bony and ligamentous elements. I mean, for example, the spine's process, the pedicles, lamina, and the posterior ligamentous parts which connect the posterior parts of the cord, of the vertebral column. The middle column includes the posterior longitudinal ligament and all of the elements comprising the posterior half of the vertebral body and the vertebral disc. The anterior column is comprised of the remaining portions of the vertebral body and the vertebral disc, as well as the anterior longitudinal ligament, as you can see in this figure. There is a three-column model of Dennis. This is the anterior column, including the anterior longitudinal ligament at here, anterior half of the body, and anterior half of the disc. Middle column, posterior longitudinal ligament at here, which is anterior to the dural sac, and posterior half of the body and posterior part of the disc. While the posterior column contains all these pedicles, lamina, spinous processes, and interspinous ligaments, like ligament of flavor. Then I'll go back. This is as I told you, this is the three-column model. How we classify fractures into stable or unstable with regard to this system. If there is injury to two or three columns, then the fracture is called as unstable. While a fracture affecting only one column, this will be stable fracture. So that if the anterior column is affected only, for example, by hyperflexion with anterior injury to this, and this one is still intact, and this is still intact, this is stable injury, stable column. Posterior also, only posterior, all of this intact, so this is also stable. If two columns, and we cannot imagine that single column affecting only the middle column. It is impossible. Maybe the anterior with the middle, the posterior with the middle possible, but the pure middle is impossible. A pure anterior possible, pure posterior possible. So that affection of one column anterior alone, posterior alone will result in stable fractures. Two columns, whether anterior plus the middle, posterior plus the middle, or anterior, middle, and posterior, this is called as unstable fracture. So that injuries with incompetence of two or three columns are referred to as unstable. The three-column theory applies to the thoracolumbar spine and only or mainly. Now, spinal injuries can be classified also according to morphology into the following types: wedge fracture, fracture dislocation, dislocation alone, common due to abrasive fracture, avulsion fractures, or transverse and spinal process injuries. Now, wedge fracture, wedge compression fracture, here there will be hyperflexion trauma as the first type of trauma, which mechanism of trauma, as I told you just previously. The fracture is stable. Why? Because it's affecting only the anterior column. The cord is undamaged and is in no danger. Fracture dislocation, here, for example, hyperflexion accompanied by rotation. Obviously, this is an unstable fracture because it affects the anterior and middle column. Commonly, there is damage to the spinal cord and nerve roots. But also, because the dislocation may affect the anterior, middle, and posterior as well, so that three columns are affected. Dislocation, pure dislocation without fracture is possible in the cervical spine because of its articular process are rather horizontal. Comminuted or burst fracture, this is an uncommon injury. If at the time of vertical compression the spine is straight, the vertebral body is comminuted, ligaments are not ruptured, and the fracture is stable. Put in your mind the following, that the fracture is stable if the ligaments are not ruptured and still in place. I mean the compression is included inside the for example the side of the body only, not go back posteriorly. If it go back posteriorly, I mean bone pieces go back and compress on the cord or dural sac, there will be injuries and the fracture will be unstable. Avulsion fracture of transverse process and spinal process are not accompanied by neurological injury and require no special treatment. In fact, they are type of posterior column injury only. Posterior only these posterior parts like transverse process or the spinal process, and they are truly a type of stable injury and need no intervention. For example, this is anterior wedge fracture. We can see that the anterior part is affected at here. Only one column of the anterior column is affected. The middle posterior is still stable. So this is stable injury. While this is fracture dislocation, typically affect one, two, all three columns are affected. This is unstable. Comminuted fracture, now you can see that these pieces slightly go anteriorly, affecting only the anterior column. The middle column is still patent and no compression or no backward compression of the cord, and the fracture is stable as well. But as I told you, if pieces of this burst fracture go backward, this will be changed to something like this, like dislocation, and it will be unstable. Regarding neurological injuries, in fact, to know the condition of the patient, whether paraplegia or quadriplegia, is the result of injury of spinal cord, nerve root, or both. It's important to diagnose the level of the lesion, number A, as well as the nature of the lesion, whether recovery is expected or not. When we say the level of the lesion, I mean, is the lesion in the cervical? Is it in the thoracic? Is it in the lumbar region? And this is regarding the level. While regarding the nature of the lesion, is it complete or incomplete, as we are going to see now. We have what's called spinal cord transection. It produces an early stage of spinal shock with complete flaccid paralysis below the line of cord section, loss of tendon reflexes, and an atonic distended bladder. Spinal shock lasts for a few days. The cord below the level of transection then recovers reflex function, which result in spastic paralysis and a reflexly emptying bladder. This is the complete spinal cord transection. In spinal shock phase, cord transection is suspected with the following findings. If there is complete loss of all forms of sensation below the level of the lesion, in concussion, joint position sense, which ascends in the posterior is preserved. Now, if the sensory loss and paralysis rises after injury, this will indicate ascending edema. A damaged cord, which has not recovered in 48 hours, will never recover at all. So this will be a complete transection of the cord. Now, what about the clinical features and presentation of spinal cord injuries? You can imagine pain, vital signs, external features, weakness, sensation, reflexes, sphincters, as I'm going to talk to you now. First of all, pain. We can imagine pain to be locally, mainly local pain due to bone or soft tissue injury, radicular pain due to nerve root compression. So that the cause of pain in spinal cord injuries either due to the site of a trauma, for example, thoracolumbar area, there will be a backache at the site of injury, and maybe radicular pain, for example, pain in the lower limbs, or one of them, or the upper limbs, or one of them due to the nerve root compression by the fractures or injury. The vital signs, in fact, bradycardia will be present, indicating loss of sympathetic input to the heart from cervical or high thoracic lesions. Hypotension due to loss of sympathetic input to the systemic vasculature, resulting in spinal shock as well. Regarding external features of spinal injuries, on examination, local examination, there will be tenderness, bruising, or swelling due to local soft tissue damage, palpable step off due to malalignment, like for example dislocation. Paraspinal muscle spasm is quite apparent. Torticollis due to muscle spasm or unreduced vertebral dislocations. Regarding weakness, we must know whether this weakness is partial versus complete. Is it complete weakness? I mean paralysis, or partial paresis. Level, how you diagnose the level of motor weakness. Motor level is defined as the most caudal level with grade 3, I mean anti-gravity strength, assuming that more cranial levels have a grade 4 strength, and that will be the level of weakness. Sensation, is it absent sensation, or decreased, or hyperesthesia? Either absent, decreased, or hyperesthesia. And the level, since the level is defined as the most caudal determinatome with normal sensation. In fact, sometimes saddle region needs to be tested. Maybe the only region of reserved sensation and called sacral sparing. This is done by proper examination, and in your books, I'm sure that of a clinical examination of the patients, you can see the diagrams who are showing you the dermatomes of sensory innervation of the upper and lower limbs and even of the trunk. Reflexes, are they normal, absent, or increased? Normal present, absent in the early stages while increased later on. Absent reflexes may indicate the presence of spinal shock, while increased may indicate the presence of an older complete or incomplete injury. First of all, at the spinal shock state, there will be flaccid paralysis, but after that, there will be a spastic paralysis and increased reflexes, hyperreflexia. Sphincters, decreased or absent tone, loss of voluntary contraction of the sphincter, or loss of bulbocavernosus reflex. Regarding radiology and how to examine and to read the radiological, what are the radiological features of spinal cord injuries or spinal injuries in general, you know that we are used for plain X-rays, CT scan or MRI to be done. As I told you always that plain X-rays for spines, you must take the AP view and lateral view. And besides AP lateral view, special view through the open mouth is needed to diagnose fractional dislocation of the atlas vertebra, which are not be shown by the AP lateral views. Cervical spinal film should show all 7 cervical vertebrae plus T1, the first thoracic vertebra. CT and MRI must be done to assess encroachment on the spinal cord. You know that CT will show me the state of the bone, while what about the cord compression or nerve roots? They will be shown clearly by MRI. For example, you can see in this lateral view of cervical spinal X-ray, a spinal cord transection is likely due to dislocation of C2. This is C1 and this is C2, dislocation of C2 over C3, the malalignment. This one go anteriorly, and you can imagine that the vertebral canal at here, spinal canal, the spinal cord may be transected at this level, and as far as it's very high level, respiratory paralysis and death may be happened during to this injury. This is wedge compression fracture, as you can see here. You can see that this normal. The anterior part of this vertebra is compressed while the posterior part is still open. So this is one of the type of compression, hyperreflection, and affecting only anterior column and mostly stable fracture. This one showed to me, for example, encroachment on the cord by bone fragments from the body of the vertebra. As you can see, this is T8, 8th thoracic vertebra. Regarding treatment of spinal injuries, treatment of spinal injuries will fall into these 4 parts. A, initial evaluation, initial acute management of spinal cord injuries and evaluation. B, subsequent management principles of the unstable spine. C, indications for decompressive surgery. And lastly, to talk about treatment of medical complications associated with cord injuries. Regarding the initial acute management of spinal cord injuries, include immobilization, steroids, and systemic measures. Regarding immobilization, for the cervical spine, by using cervical collar. As I told you when I spoke about head injuries, I told you that any case of head injury is associated with cervical injury until proof otherwise. So that traumatic cervical injury should be presumed to be present until it is ruled out by physical examination and appropriate radiographic studies like X-rays. Thoracolumbar stabilization or immobilization done by maintenance of a neutral position during the pre-hospital phase. The trauma victim is moved on to the stretcher all in one piece. He should never be lifted by the shoulders and the thighs. So that transfer of patient should be as just one block or one piece, assuming that there is thoracolumbar injuries. Until we will be sure 100% that there is no injury, then we can let the patient move freely. Steroids patients with spinal cord injuries who were treated with methylprednisolone within 8 hours of injury had significantly greater improvement in their neurologic function than those given a placebo. I would concentrate about this point regarding the first 8 hours. I mean, he arrived within 8 hours of the injury. If he arrived to you after 8 hours, no benefit of this. In the last years, in fact, there's controversy about this principle of the first 8 hours with regard to methylprednisolone. Sometimes we are giving the patient this steroids. Also, in the initial acute management of spinal cord injuries, systemic measures regarding respiratory, cardiac, and genitourinary. Respiratory maintenance of adequate airway and breathing remains the first priority in the trauma patient, as we know that ABC are first priority in any trauma patients. Cardiac hypotension due to loss of sympathetic vascular tone and bradycardia due to loss of sympathetic innervation of the heart are the most important elements of spinal shock due to spinal cord injuries and must be treated by supplying the patient with fluid and something to elevate his blood pressure. Genitourinary replacement of an endoline catheter for a Polish catheter is mandatory in the severely injured patient for monitoring their output volume. And also if he is having, for example, retention of urine. Continuous urinary drainage prevents the complication of bladder rupture due to over-distension. Subsequent management of principles of the unstable spine by either decompression of the neural elements, mobilize the patient as soon as possible, and stabilize the spine. Regarding compression of the neural elements, have special indications, which I'm going to mention to you in the next section. Mobilize the patient as soon as possible to prevent atelectasis, pneumonia, deep venous thrombosis, and decubitous ulcers, but be sure that this is stable fracture, or after you stabilize the unstable fracture. Stabilize the spine that's not likely to heal without surgical intervention by arthrodesis or fusion and by internal fixation spinal instrumentations. Now, we are doing a lot of these surgeries in our city with high results of success, alhamdulillah. And just to mention to you that all these instrumentations nowadays are done by MRI compatible screws of titanium. So that you will be, for example, a radiologist in the future and you are faced with patients having spinal fixation, there is no contraindication for MRI in this patient for any area of the body because these screws are made of titanium, which is MRI compatible. Regarding indications for decompressive surgery, the most important indication for decompressive surgery in spinal cord injury is the presence of an incomplete neurologic injury with persistent neural compression at the site of injury. I mean to remove the compression from the cord or nerve roots to get relief, and the patient will benefit a lot. Compression may be due to end-driven bone fragments, or traumatic herniation, or epidural hematoma, or persistent vertebral malalignment like dislocations. In all these cases, we will be in need for decompression and mostly with fixation if it is an unstable fracture. The last topic of this lecture, I'm going to talk about the treatment of medical complications associated with cord with cord injuries. First of all, care of the skin. You know that bed sores in unmoved patient are quite vulnerable, and this is quite dangerous. Bed sores develop rapidly unless the patient is well nursed. The skin is kept clean and dry. The skin is washed, dried, and powdered. The patient is turned over every 2 hours, and we must concentrate about this point to the patient family. When I say that every 2 hours, I mean, for example, 2 hours on the back, 2 hours on the right side, 2 hours on the back, 2 hours on the left side, 2 hours on the back, and so on. And when I mention to the patient family, I concentrate on it by the following: to tell them that when I said every 2 hours, I mean 2 hours, not more than 2 hours. For example, at 8 a.m., and then 10 a.m., 12 p.m., 2 p.m., 4 p.m., 6 p.m., 8 p.m., 10 p.m., 12 a.m., and the forgotten times of 2 a.m., 4 a.m., and 6 a.m. The patient family will get into sleep, for example, at 12 a.m., and they will still sleep, and the patient will still on one side, for example, on the back or one right or left side, until the morning. This means at least more than 6 hours, and he will get bed sore. Once bed sore, it will be uh, severe trauma to the patient. Established bed sores need general treatment and nutritive guide to build the patient's resistance. Sloughs are removed and daily dressing are applied in the preparation for skin grafting. Regarding care of the bladder is kept empty by an indwelling catheter. Stroking the side of the thigh initiates bladder contraction. The lesion of the cauda equina, in lesion of cauda equina, the bladder remains paralyzed and micturition occurs by abdominal straining. I mean, the patient will press on his lower part of the abdomen and he will urinate. Otherwise, no urination. Urinary infection is prevented by attention to the asepsis during catheterization and to change the catheter, first catheter let me say, every 1 week. Patient left with high residual urine needs special investigations, including cystography and cystometry. Transurethral resection of the bladder neck or sphincterotomy may be indicated. In fact, we are telling the patient family the following, that when we put the Foley catheter for the patient, what will happen? The bladder will be emptied totally. And then, day after day, the size of the bladder will get smaller and smaller. There will be shrinkage of the bladder because there is no distension of the bladder by urine. So, first of all, we are going to do training of the bladder exercise by blocking the Foley catheter. And then what will happen? Urine will be collected inside the bladder. And then we will open the Foley catheter every 2 hours. Every 2 hours for 10 minutes for evacuation of the bladder. This exercise will let the bladder get swelling and return back to its normal size. Then, after 2 weeks of this exercise, we will ask the patient family to remove the Foley catheter at the early morning, but preparing other Foley catheter and gloves and urine bag and everything we are needed, like xylocaine gel, and expert person in putting the voice catheter. They remove them, for example, at 8 a.m. at one morning. Then ask the patient to drink a lot of water to get the bladder swollen and filled with urine. Then take the patient to the water cycle and let him to try to urinate by himself. How he will urinate? By pressing in the lower part of the abdomen near the pelvis. This pressure will result in initiation of a bladder contraction and the urine will be out. Now the patient will be controlling his bladder by other method than our normal method of controlling by the urethral sphincter. Here he will control that his urination by passing urine only after pressure on the lower abdomen. And if this failed, we will return back the voice catheter into place and continue the exercise. And every 2 weeks, we will repeat this trial of removal of the voice catheter. Regarding bowel training, enema is done every third day. Mild laxatives may be needed. The patient is trained to strain and evacuate the bowel by himself. In fact, this is quite a big problem to the patient and his family. Muscles and joints contractures are prevented by passive movement of the joint. We will ask the patient family to do exercise for their patient for their benefit. Otherwise, there is no benefit from without if any of any, for example, treatment without the exercise. Positioning is also important, particularly for equine deformity. Established contractures may need correction by tenotomy by the orthopedic department. Rehabilitation of the permanent paraplegic. The trunk and shoulder muscles are developed so that the patient can sit up and use his arms to turn himself and hold crutches. A wheelchair may be used for life. Ambulation using leg braces and crutches may be possible. In fact, spinal injuries, to say the last words about this disease, which is so drastic to the patient and their families, and they will feel themselves as a heavy object on their families. And يعني مثل ما نقول احنا باللغه العربيه نقول اصبحوا عاله على اهلهم. فيعني مساله العلاج ما فقط انه العلاج اللي ذكرناه الامور، وانما العلاج النفسي كلش مهم. ان نشجع encourage the patient to get into normal life as much as he can, and let the family be helpful to their patients, and encourage them and letting them think that they are normal persons. In fact, it is a horrible disease, horrible thing to affect the human, and we are faced by many patients like this. Okay, نسأل الله المعافاة لنا ولكم جميعا من هذا المرض. Thank you very much for all of you. والسلام عليكم ورحمة الله وبركاته.